Hello, welcome to the first part on a series of video lectures on pneumothorax. Let us understand what pneumothorax is. The term pneumothorax comes from the Greek word pneuma. Pneuma means air and thorax means the thoracic cavity or the chest. So by the name itself, we understand that pneumothorax is an abnormal collection of air in the pleural cavity. Just a quick basic refresher of the anatomy. If this is the thoracic cavity, obviously it would be bounded by the thoracic cage made by the ribs and the intercostal muscles. This right here is the lung, the right lung, and here is the pleural lining. The pleural lining that attaches to the chest wall is known as parietal pleura, and the pleural lining that attaches to the lungs is called visceral pleura. And if there is an abnormal collection of air within this space, it's known as pneumothorax. And I tell you that it is an abnormal collection because any collection of air in pleura is an abnormal collection. Now, before we discuss about pneumothorax in much more detail, let us understand a few MCQ points that might be relevant for medical students. The first thing is normal amount of pleural fluid per day is 5 to 15 ml per pleural cavity. A normal daily production of pleural fluid per day is about 0.1 to 0.2 ml per kg every hour, and that basically amounts to about 10 to 20 ml per day of pleural fluid per lung. The pleural fluid is produced as well as absorbed by the parietal pleura. So what produces pleural fluid are the capillaries of the parietal pleura. Again, just a reminder, parietal pleura is the pleura that attaches to the chest wall, and what drains the pleura is the lymphatics of the parietal pleura. Right. So my trick during MBBS was to learn topics under certain headings, and these headings were consistent among all of the diseases. So always start with the definition, then move on to the classification of the disease. So let us broadly classify pneumothorax. And I think a lot of medical students have a confusion about what is an open pneumothorax, where does a spontaneous pneumothorax fall into place, what is a tension pneumothorax. So just to make things clear for you and to ensure that you don't have the same confusion as I did when I was a student, let us broadly classify pneumothorax into two broad headings. The first kind of pneumothorax is traumatic pneumothorax, which means that there has to be some traumatic event for a pneumothorax to set in. Another type of pneumothorax is spontaneous pneumothorax, where there should be an event, but the event is not quite obvious. And I'll explain it in a bit, and it'll make more sense to you. So classifying traumatic pneumothorax, we can see that if there is a breach in the chest wall, either in the anterior chest wall, lateral posterior chest wall, that is known as an open pneumothorax. But if the chest wall is intact, that means it's a closed pneumothorax. So what are some of the conditions where you might see a traumatic pneumothorax? Of course, in any blunt force trauma to the chest. For example, motor vehicle accident, also known as road traffic accident, etc. But there are some other conditions where there might be trauma to the chest. And mind you that a traumatic pneumothorax, a road traffic accident, might cause an open pneumothorax or a closed pneumothorax. Other causes are stab injury, which would obviously cause an open pneumothorax. Barotrauma in mechanically ventilated patients. Usually, if it is a prolonged intubation ventilation, it usually predisposes people to developing barotrauma. And also during iatrogenic procedures. For example, during pleural tapping, you might introduce air into the thoracic cavity, pleural cavity, and that causes pneumothorax. So pleural tap. Sometimes during opening of central lines. So when central accesses are made, sometimes the guide wire or the catheter punctures the apical pleura, causing pneumothorax. Now, this is traumatic pneumothorax for you. Spontaneous pneumothorax can be divided into two types. First type is primary spontaneous, and the second type is secondary spontaneous pneumothorax. Now, what does that mean? Like I said, there should be an event, but the event is not quite evident in the beginning. So what does that mean? In a typically young, healthy, athletic male, in the questions, I think they ask you They give you a scenario of a male who is in his adolescent age, is a basketball player, develops sudden onset of pleuritic kind of chest pain followed by breathlessness. That is the sequence with which questions will come to you. So if any young, tall, athletic male, while playing basketball typically, but while playing any sports, usually involving raising of their hands, develops sudden onset of chest pain followed by shortness of breath, they're trying to tell you that this person has developed primary spontaneous pneumothorax. What does this term primary mean? Primary means the underlying lung is healthy. Sometimes they might give you a scenario of a female usually develops chest pain during menstruation. They did a chest x-ray and found out pneumothorax. Sometimes this can be a rare variation of endometriosis of the thoracic or pleural cavity. Sometimes 3% of the primary spontaneous pneumothorax in females can be because of endometriosis of the pleural cavity, and this is known as catamenial pneumothorax. Again, not a very common disease, but it's an interesting thing to learn about. Now, what does secondary mean? Secondary means that the underlying lung is unhealthy. For example, any condition or any disease of the lung which might precede pneumothorax or which might be a direct contributor of pneumothorax causes secondary spontaneous pneumothorax. So when the underlying lung is unhealthy, for example in COPD, might have large bulla inside the lungs which may rupture and cause secondary spontaneous pneumothorax. Sometimes pneumonia, usually the cavitary pneumonia or cystic pneumonia, can cause pneumothorax. Other examples could be cystic fibrosis, alpha-1 antitrypsin deficiency, asthma, bronchiectasis, you name it. So in any diseased lung, if the person develops a pneumothorax, it's known as secondary spontaneous pneumothorax. Why this classification? It's because the treatment of primary spontaneous and secondary spontaneous might be quite different. We'll be discussing that in another video. Now, where does tension pneumothorax come into play in all of this? For now, let us just remember that there's another clinical entity which is known as tension pneumothorax, which is outside of this classification system, which means that any of these pneumothoraces can go into tension pneumothorax, but we'll discuss that later on. Now, the next heading we are going to discuss about is the etiology. Like I told you, sometimes it can be a primary spontaneous pneumothorax where there's no significant etiology might be evident, but it's usually because of subpleural blebs in these young athletic males, and whenever they play any games that involves raising their hand above the level of the head, it might rupture the pleura, causing pneumothorax. Other causes, like I said, could be road traffic accident, underlying diseases, mechanical ventilation. In females, quite rare, but it can be a catamenial pneumothorax. And sometimes it can be iatrogenic also. Right. Now, let's understand what is the fuss about pneumothorax. Why are we worried about air coming into the pleural cavity? Now, before we go into this chart, let us revise the most basic of physiology of respiration. And there are certain factors that are responsible for respiration. For example, the outward movement of the thoracic cage, the pattern at which our ribs are placed, the anatomic, the way nature or God has made our thoracic cavity, the direction of the intercostal fibers, the movement of the diaphragm, and in conditions where patients they have some disease processes causing increased work of breathing, there are secondary muscles of respiration, that all of these factors come into play when a person respires. All of these factors come into play to make a person able to breathe. But among all of these, there's one more mechanism inside the body that helps suck air into the air, and that is the resting intrapleural pressure. So you need to understand there are two pressures we're talking about here. One is intrapleural, and another pressure is intrapulmonary. So, we all know that the atmospheric pressure is 760 millimeter of mercury. The normal resting intrapleural pressure is about 756 millimeters of mercury. So compared to the atmospheric pressure, there is a negative 4 mmHg to negative 5 mmHg of intrapleural pressure. So what happens is, for a normal respiration to take place, this negative intrapleural pressure will go even below its value as the thoracic cavity, as the thoracic cage enlarges in size. So diaphragm starts to move down, and the the chest wall starts to expand, and this creates a significant drop in the intrapleural pressure. So this can be seen in this diagram right here. So normal resting intrapleural pressure is -5 mmHg. It starts to drop as the chest wall starts to expand. What does that do? It allows it kind of creates like a vacuum for air to be sucked in from the atmosphere into the lungs. So what does what happens with the lungs is, now air can freely move from the atmosphere into the lungs, resulting in the expansion of the lung. And with inspiration, slowly the alveolar pressure starts to increase, and slowly the lung volume starts to increase. And reverse happens when the person has to expire. The intrapleural pressure starts to increase because the chest wall cannot expand beyond a certain limit. So the chest wall starts to contract. That increases the intrapleural pressure, takes it to the baseline of -5 mmHg. That increases pressure inside the lungs. So that's inside the alveoli. That's the alveolar pressure, intrapulmonary pressure. As the intrapulmonary pressure starts to increase, the lung volume starts to decrease, and that is how air is pushed out from the lungs. All right. So in pneumothorax, what is happening is, because there is air inside this cavity, now since it is air, the pressure inside the pleural cavity it normalizes with that of the atmospheric pressure. So pressure inside the pleural cavity will become 760 millimeters of mercury. Now you can imagine this. If the intrapleural pressure and the atmospheric pressure are equal, if the pressure outside the body and inside the pleural cavity is equal, one important mechanism that helps to suck air into the lungs does not work. Now, because this does not work, the lungs cannot expand because the affected side of the lung cannot be filled with air. The lung starts to collapse. So the effective size of lung starts to decrease. When the lung starts to collapse, of course, the alveoli cannot take in air, so there's no exchange of gases. So that means the affected side of the lung essentially cannot work as much as it should. And that, of course, creates significant changes in the blood oxygen levels, and also is the reason why patients will develop shortness of breath. In another scenario, let's say there's some chronic disease, let's say there's some interstitial lung disease which affects this person, but that event is developing slowly. Let's say over 8 years, 9 years, 10 years, this lung slowly becomes non-functional. Or imagine there's a collection of pus outside of the lungs in the pleural cavity, does not allow that adjacent segment of the lung to expand, but this improper expansion happens over many years. How does the body react? The body reacts by hyperinflating the contralateral lung. The remaining healthy lung becomes larger in size and takes up the function of the collapsed segment. So that is how body compensates. But in pneumothorax, everything is happening within a minute, within a matter of minute or hours. So body does not have the same duration of time to compensate for this loss of effective volume of lungs and effective surface area for taking in oxygen and giving out carbon dioxide. That is why patients will start to develop shortness of breath. However, the initial complaint in almost all pneumothorax cases will be pleuritic type of chest pain, because the air starts to irritate the parietal and visceral pleura. That will cause inflammation, and inflammation, of course, there are different signs of inflammation, one of which is pain. Right. So this is what happens in pneumothorax. And now let's say there's a small breach in the lung. Maybe, let's say it's a traumatic pneumothorax. The ribs fractured and then punctured the lungs, and so there's a small breach in the lungs. Continuously, air is leaking out into the chest, into the pleural cavity. The increase in volume of this air will start to compress on the lungs. So the lungs will collapse even further. So imagine if this was the normal size lung. Because of pneumothorax, it collapsed, and because of ongoing evolving pneumothorax, the size of the lung collapses even further. Now, all of us know the mediastinum, also the thoracic cavity, is again a confined space. It has a limited volume. Beyond a certain point, the pressure inside this system will go so high that the air will start to push not just the lung but also the heart on the opposite side. So what does this do? And another important structure in the mediastinum are the great vessels. So we have the pulmonary artery and the aorta in the mediastinum. Of course, these are also going to be kinked. These are also going to be pushed towards the opposite side. What does this do? It does not allow the heart to fill as much. So the effective end diastolic volume will decrease. As the end diastolic volume will decrease, cardiac output will decrease. When cardiac output decreases, as we all know, body tries to compensate by increasing heart rate. And that is why these patients will start to have a drop in BP, increase in tachycardia, increase in the heart rate. Of course, because one lung is not functioning well, they have to try to compensate. The work of two lungs has to now be done by the normal healthy lung. So of course the heart rate will the respiratory rate will start to increase. The patient will have drop in BP, tachycardia. So this clinical entity of pneumothorax with hemodynamic compromise is known as tension pneumothorax. And as I told you before, any pneumothorax can go into tension pneumothorax. It is not just traumatic. Primary, secondary, any pneumothorax can go into tension pneumothorax. Now, what are the factors that might predict the rapidity at which pneumothorax develops and the rapidity at which tension pneumothorax develops? There are two basic determinants. Now, these are quite theoretical concepts just for you to write. Although even small breaches in the lung parenchyma, which are known as alveolo pleural fistulas. As you can imagine, an alveoli or a bunch of alveoli, if they rupture, again, it's not going to cause a big hole in the lung, but sometimes even alveolo-pleural fistulas can cause persistent pneumothorax. So again, this is quite a theoretical discussion, but there are two different determinants of how rapidly a pneumothorax will develop, and that is the size of the defect and the rate at which air accumulates. So again, this is just for you to write in your exams. Might not be able to you might not be able to find this clinically on patients though. Now, as I told you before, once there is air in the pleural cavity, the body responds through inflammation, and the end point of inflammation is fibrosis, healing by fibrosis. So as the pleura starts to heal by fibrosis, sometimes this breach in the lungs is it's like it's glued by the pleura, which will spontaneously resolve the initial cause that might have caused pneumothorax. Sometimes it happens, sometimes we have to manage it through pleurodesis, and we'll discuss that in another video. So that was about the pathophysiology of pneumothorax. And let us look at what would a patient present with when they come to you with pneumothorax. And with every condition, I would suggest you to study based on the when you take a history, and when you study also, you should always study based on the cause, condition, and complication. So whenever you're taking a history of any condition, be it pneumothorax, pneumonia, or anything, heart failure, any gynecological condition, appendicitis, in any subject, I would suggest you to take history based on at least the HOPI component should be based on the condition, cause, and complication. Doing this would help you in your clinical practice, because you would have to think about what might be the possible complications of disease, and then that would help you sometimes to rule out or rule in red flag signs, and potentially help save lives of patients also. So like I told you, cause basically means etiology. So it could be trauma, it could be spontaneous, it could be catamenial. So in a history, they might tell you history of chest pain, maybe shortness of breath during their periods, cyclical history in females every month when they get a period, and then underlying history of COPD, asthma. All of these things are important. So one important risk factor is smoking. As you might know, a smoker does not need to develop COPD to have pneumothorax. Smokers might have subpleural blebs, which might rupture and cause pneumothorax. Now, how do you basically know it's a pneumothorax? Usually the sequence of symptoms that present to you in most of the patients is chest pain followed by shortness of breath. This is more evident in primary spontaneous pneumothorax, but in secondary spontaneous pneumothorax, they might have shortness of breath already because of, let's say, COPD and pneumonia and things like that, and then they might develop chest pain later on. Now, what are the complications of pneumothorax? Now, these people might be too breathless to speak. Of course, that would mean that they might have cyanosis. That's bluish discoloration of the skin and mucous membrane. If they have tension pneumothorax, that would mean that their hemodynamics is compromised. And a patient with compromised hemodynamics, they might present to you with syncope or loss of consciousness. And of course, you might have to think about other injuries too in any patient with RTA. So if pneumothorax is the most obvious clinical presentation of an RTA, you should still not forget about the head, about the long bones, about the abdomen, about the pelvis, and about other possible, about the back, about the spine, and about other possible areas of trauma. Now, what might be expected in a patient with pneumothorax, and this is mostly in tension pneumothorax. Some people might ask you the vital signs criteria of tension pneumothorax, although it has not been, I would say, validated in any of the studies, but a good thing to keep these things in mind so that it can increase your index of suspicion while evaluating a case of pneumothorax is tachycardia, more than 100 beats per minute. Somewhere it's written 110 beats per minute. Tachypnea, more than 24 breaths per minute. Somewhere it's 22. Hypotension, everywhere it's written less than 90 millimeters of mercury systolic. And hypoxia, less than 90% saturation in room air. What would you expect in a respiratory examination? When you inspect the affected side of the chest wall, might not move equally compared to the other side, and there might be tracheal deviation if the person has tension pneumothorax. In palpation, you confirm these things. So you confirm that there's a decreased chest wall movement on the affected side and there is tracheal deviation. But one more thing that you need to understand is if there's paradoxical movement of the chest wall in a trauma patient, there might be flail chest on top of a pneumothorax. So that should be in your mind also all the time, and that just complicates the treatment and prognosis for the patient. On palpation, other thing that you can do is ask the patient to speak, and usually we ask the patient to say 111 or ek in Nepali. So that would mean that we're just trying to check for tactile phlebitis, and so the tactile phlebitis would either be decreased or absent. On percussion, again an MCQ point, there would be hyperresonance. But this can, this mostly is a theoretical, finding, because usually these patients present to you in the ER, and it's very difficult to hear the sounds. You would have to be quite experienced to differentiate whether it is a hyperresonant sound or a dull sound on percussion, but it's a good idea to practice. And on auscultation, of course, if there is no lung there, there's not going to be any breath sound. So absent breath sounds. And there's another thing that you can elicit. It's called vocal resonance. Same as tactile resonance, ask the patient to say 111. But as with tactile resonance, you don't put your hand there, you put your steth. So decreased or absent vocal resonance. So these are your clinical findings in a patient with pneumothorax and tension pneumothorax. Now, things have advanced quite a bit now. So I think all medical students should be able to at least do a bedside ultrasound, especially to diagnose conditions like pneumothorax. So what do you do? In any traumatic patients, you do an E-fast. So when you do an E-fast, when you look at the lungs, in the lung window, a normal pleura, so if this is the rib shadow, this is the rib shadow, in between the two ribs lie the pleura. A normal pleura, if there is a lung, has to slide. So the normal pleural sliding will appear as seashore sign on an ultrasound. How do you see? So this is done in M mode. And in M mode, when you put the ultrasound probe in M mode, the ultrasound machine gives you a line. And there are markers of depth. So if let's say this is 1 centimeter depth, we can see the pleural shadow, and this is reflected on the motion mode graph that comes when you select the M mode. So in 1 centimeter depth, you can see that the pleura is not sliding. A seesaw sign would appear as something like this, because when the pleura moves, the motion mode detects, the ultrasound machine detects this motion, and it gives you a sign known as seesaw sign. But as you can see, there's no seesaw here, and there's no motion detected above it and below it. And these straight lines that appear in M mode are known as barcode sign. This is what you see in an ultrasound of a pneumothorax. But one more thing that I would like you to consider here is, sometimes in pneumothorax, the pneumothorax is not as large to occupy all of the thoracic cavity. So let's say when you're examining the patient, you have a probe placed here, right here. So when you take the motion M mode picture of this area, there would be absent lung sliding in this area because there's no lung there. There's no there's basically just air there. So you would see barcode sign, but in the same window there's lungs here. So of course there will be pleural sliding there, and in the same window you'll see seesaw sign here, if that makes sense. And this would be between two ribs, one rib shadow, another rib shadow. This particular area where there is transition between barcode and seesaw sign is known as lung point. And quite often you would have to search for this lung point during an ultrasound. This would make more sense when you actually do an ultrasound on a patient, but understand that there is something known as lung point. So sometimes it's not evident in every patient. You might be confused whether this is pneumothorax or not. When you're confused if there's pneumothorax or not, you always look for a lung point. That means you look for the place with your probe where there's also pneumothorax, also healthy lung tissue. All right. Another investigation we send is chest X-ray. But before I talk about chest X-ray, let me just tell you that tension pneumothorax is always a clinical diagnosis, and this will be tested in MCQs also. It's a clinical diagnosis. You never wait to diagnose tension pneumothorax. You never wait for a X-ray, maybe even ultrasound. Not all centers have easy access to ultrasound. Not all centers have people who know how to do an EFAST. So for any emergency medicine physician or any intern medical student seeing a patient in emergency department, you need to be able to diagnose tension pneumothorax clinically. So just a reminder, if you have signs of pneumo plus hemodynamic instability plus tracheal deviation, hyperresonance, absent breath sounds, all of these things, then you have to diagnose the patient with tension pneumothorax, right? But in other conditions, you can wait for a chest X-ray to come before intervening. Now, let's look at the first chest X-ray here. So I like to look at the trachea first. The trachea is quite in the midline, and the carina is not quite visible here. The right lung appears normal to me. Ribs also, they're normal. So the right side of the chest or the right side of the hemothorax looks normal to me. The right hilar vessels also look normal to me. But on the left side, I think you can appreciate this hyperlucency, this area of hyperlucency right here. And the term lucency is used, or opacity is used, for chest X-ray. So this area of hyperlucency, couple that with this structure right here, where you can see a collapsed lung with bronchovascular markings within. This is pneumothorax, and it's quite a large pneumothorax. Almost all of the left side of the hemithorax is occupied by air. But not all pneumothoraces are as obvious or clear as this picture, because if you look at this picture right here, you can see a hyperlucent area in the left hemithorax. You can see the pleural border right here, this radio-opaque line. This is the visceral pleura, which is not evident in a normal X-ray. Like in this X-ray, you can't separate which is the visceral pleura, which is the parietal pleura, although you can see a pleural line right here. So this is the visceral pleura, which is now quite evident. This is the collapsed lung, which is collapsed due to pneumothorax and has normal bronchovascular markings. As a matter of fact, it has slightly increased bronchovascular markings. This is because as the lung collapses, the density of the lung increases, and as the density of the lung increases, it impedes more X-rays, making it appear more white. So this might not be pneumonia, might be pneumonia that is to be diagnosed later on, but this X-ray shows pneumothorax on the left side. However, if you can see here, the lower right lung is also collapsed, and there's some hyperlucent area here. And sometimes pneumothorax can be loculated like this or small in size, known as minimal pneumothorax. Might not be quite evident, but you have to look at all of the quadrants of the chest X-ray, both the hemithoraces. Don't focus just on the most obvious findings. Also try to look for other areas. This X-ray is actually of a patient with bilateral pneumothorax, left more than right. And sometimes X-rays are not very good. Could be because of the operator, because of the view. So if it is an anterior posterior view, you have to look at more than one sign of diagnosis. So just at a quick glance, this X-ray appears to be normal to us, but as you can see, the trachea is deviated to the other side. Very well, it could be because of rotation, which I strongly believe it's because of rotation. This seems to me like an AP view X-ray, but what you can see here is there's a hyperlucent area here, and sometimes because of the rib shadow, you might not be able to appreciate the hyperlucent area. So where you have to look for is between the ribs in the intercostal space. So this black area, these black areas are hyperlucent shadows. This shadow right here is the border of the scapula, and this right here is the border of the lung. So this actually is left-sided pneumothorax. Findings are not quite evident, but you have to look at different findings to support your diagnosis. So what are the findings that we can see? You can see one lung margin here, two bronchovascular markings till here, absence of bronchovascular markings indicated by hyperlucency in the chest X-ray here, and another point would be deviation of the trachea to the opposite side. So just remember the name. For the purpose of MCQ, you don't have to memorize the formula for your clinical practice or for your exam. I don't think anybody is going to ask you, but what you need to know is what the British Thoracic Society guidelines tell you about the size of pneumothorax. So imagine this, you get a chest X-ray, and so there's a pneumothorax and there's collapsed lung. Now, the British Thoracic Society guidelines say that at the level of hilum, and how do you recognize the hilum? Of course, there would be hilate vessels. So at the level of hilum, when you measure the size, measure the distance between the parietal pleura and the visceral pleura, or in other words, when you measure the size or the length of the pleural cavity, if it is more than 2 centimeters, they say this is a large pneumothorax. If this is less than 2 centimeters, they say it's a small pneumothorax. Now, of course, there are different other guidelines that mention 3 centimeters, 1 to 2, less than 1. Again, these are just to confuse you, because updated guidelines on management don't really focus on the size. But just to make things clear and easy for you, the 2023 updated British Thoracic Society guidelines say that if the size is more than 2 centimeters, it's a large pneumothorax. If the size is less than 2 centimeters, it's a small pneumothorax. Why this 2 centimeter, you ask? If the size of pneumothorax is more than 2 centimeters, it would mean that the effective lung volume has reduced by 50%. So whenever there is a pneumothorax of more than 2 centimeter size, it means that the lungs have reduced to 50% of the size, which might not be evident by this 2D image, but when you do a CT scan, you can find that finding much better. So again, another investigation that you can send in a patient with pneumothorax is CT scan, and like you can see in this CT scan, you have a collapsed lung. Probably this is a traumatic pneumothorax. There's trauma to the lungs, the contused lungs, bilateral contused lungs, and hypodensity collection in the pleural cavity, and this collection is air, indicating pneumothorax. Of course, you're going to send other investigations also, like full blood count. If it's a trauma patient, you do the whole ABCD protocol based on ATLS guidelines. You have to send their blood groups, cross match and everything. Urea and electrolytes, and an ABG also. ABG would be more important when you're managing secondary spontaneous pneumothoraces and also in massive pneumothoraces, just to see what is the degree of arterial hypoxemia and how you are going to manage these patients. Some other findings that you can expect sometimes in a patient with pneumothorax in both CT scan, your clinical examination, and X-rays is surgical emphysema or subcutaneous emphysema. So there might be air within the soft tissue densities in a chest x-ray or a CT scan, or when you clinically examine this patient, you might feel crepitus under the skin. So this can also be one of the manifestations of pneumothorax. Now, coming to the last part of this discussion today, we are going to see what do the updated British Thoracic Society guidelines tell us about how to manage a case of pneumothorax. And the surgical management of pneumothorax, including management of tension pneumothorax, will be discussed in another video, so please stay tuned for that. So before we discuss that, let us understand a few definition points. What the guidelines have suggested is you have to consider conservative management for minimally symptomatic pneumothoraces. So if a patient comes to you with pneumothorax but does not have significant pain, of course there's going to be some pain, but it's tolerable, and the person also does not have breathlessness, you do not need to intervene surgically. All right, there's no need to intervene surgically. For that, there also should not be any physiological compromise. Like I said, heart rate should not be increased, saturation should not drop, BP should not drop, these things. So what it means in layperson terms is that if a person comes to you, has a pneumothorax but is quite stable, clinically stable, you might not have to intervene in such cases. If it is a primary spontaneous pneumothorax, again, if it is asymptomatic, regardless of the size, in these two conditions, and either if the person is minimally symptomatic or asymptomatic, in primary spontaneous pneumothorax or any other kind of pneumothorax, you might not have to treat this patient. This is based on BTS guidelines, and this, they say, is regardless of the size. So it could be a massive pneumothorax, but no derangement in physiology, do not intervene. However, I think the reason why they say this is because if this person comes to you, of course, if this patient comes to you, of course, they are going to have some physiological derangement. Of course, their saturation is going to drop. Of course, they're going to have a bad chest pain. Maybe heart rate is going to be elevated. So things like that. So what do they suggest? In terms of the pneumothorax pathway is you have to see. So the first thing you look at a patient with pneumothorax is not the size of the pneumothorax, but if this patient has symptoms. So if the patient is not symptomatic, you might not have to intervene. But let's say if the patient is symptomatic, then you look at if this patient has some high risk characters or not. So what are high risk characters? Any patient with pneumothorax and hemodynamic compromise, known as tension pneumothorax. So any patient with tension pneumothorax is a high risk patient. Any patient with significant drop in blood oxygen levels, not just saturation, but also in ABG, if the PaO2 is reduced, that patient is a high-risk patient. Like in the previous X-ray that I showed you, if the person has bilateral pneumothorax, that makes this person high-risk because both of the lungs are now in danger. In any secondary spontaneous pneumothorax, the patient is a high-risk pneumothorax. So in COPD, asthma, pneumonia, if there's underlying lung disease, the patient is a high-risk patient. Any person more than 50 years of age with a significant smoking history. So if they have a previous smoking history, they have not mentioned about the back years, but if they have a significant smoking history, maybe a current smoker, maybe they had smoked in the past, that makes them high risk. And if it's a traumatic pneumothorax, or sometimes even in malignant pneumothorax, if it's not just pneumothorax but also blood is also present in the pleural cavity, meaning if the patient has hemopneumothorax, it makes them a high-risk candidate. So if there is a high-risk characteristic, if any one of these high-risk characteristics are present, you have to intervene. But before that, what do the guidelines say is to check if the size of the pneumothorax allows you to intervene. So what does this mean? Is the size of the pneumothorax more than 2 centimeters? And mind you, the American Thoracic Society guidelines mention something known as the apex to cupula distance. So ATS wants you to look at the top of the lungs. British Thoracic Society wants you to look at the hilum. Anywhere you look, if the size is more than 2 centimeters, it means it is safe for you to intervene and you should intervene. If it is not safe, then it would be a good idea for you to get a CT scan imaging of this patient. Now, let's say there are no high-risk characteristics, the patient is not asymptomatic, then in that condition, you perform conservative management. If it's a primary spontaneous pneumothorax, you can even discharge the patient, no need to admit. do a repeat X-ray in 2 to 4 days of time. If it is a secondary spontaneous pneumothorax, you might have to admit the patient and repeat X-ray. Some guidelines say you have to repeat X-ray in 4 hours. Some mention repeating X-ray in 24 to 48 hours. Once the check X-ray is done and both the check X-rays are normal, you ask the patient to follow up in about 2 to 4 weeks of time. And in about 2 to 4 weeks of time, if there's no pneumothorax, then you don't have to follow the patient up in the future. However, one thing that you need to understand here, and this can also be an MCQ question, and also some patients with primary spontaneous pneumothorax might ask you this. So any patient with primary spontaneous pneumothorax, if they ask you, doctor, can I scuba dive? You have to say this patient is banned for life for scuba diving. However, if they ask you, when can I travel by air? So when you do a check X-ray in 2 to 4 weeks of time after resolution of the initial pneumothorax, if there is no residual pneumothorax left, then that means this patient is safe to travel by air. All right. But however, any patient with primary spontaneous pneumothorax is banned for life for scuba diving. Again, that is based on the latest British Thoracic Society guidelines. The nature of guidelines are such that these will change, these can change. So it's your responsibility to stay updated regarding that. Now, let us not talk about these things because these things are not available in our country. Ambulatory pneumothorax management. Basically, what we have understood is we've seen the management of pneumothorax depends on the symptomatology of the patient, not the size of the patient. Size of the pneumothorax. Yes, size is important, but that comes secondarily. Also, even they mention when it's safe to intervene and when there is an indication to intervene. The British, they are very big on patient consent and patient autonomy, which I absolutely agree with. You have to explain the condition to the patient, but you have to give them an option whether or not they would like an intervention. And if the patient denies an intervention, there's effectively nothing that you can do other than to try to influence them into understanding their condition better. So again, I think the third most important factor in considering whether or not to treat a pneumothorax is also patient preference also. Okay, so what is the patient's priority? Is it to get intervention or not? If they want intervention, do they want a rapid relief? Do they want to avoid any procedures? Do they want conservative management, or do they want some ambulatory devices that are put in their chest that will slowly resolve the pneumothorax? Again, this device is not available in Nepal, but if they would like to intervene, you can do that using either needle aspiration or needle decompression or chest tube. Now, to understand the differences between these three treatment processes, stay tuned for the next video where we'll discuss the surgical management of pneumothorax. Thank you for your time and have a nice day.